Welcome back to the deep dive. Today we are finishing the story of the gastrointestinal tract. We're meticulously tracing the final, complex, and, well, highly specialized segments. The large intestine, rectum, and anal canal.
Yeah.
We are diving deep into Chapter 65 of Gray's Anatomy, and the goal is to transform those dense descriptions into a clear, structured roadmap for you.
It really is a remarkable system of plumbing. It's full of these critical transitions. Our mission today is to give you that ultimate visualization where everything sits, why it looks the way it does, and how its embryonic history really dictates its clinical realities.
That was the foundation.
It's the foundation. If you want a quick, accurate foundation for understanding disorders in this region, this is, your shortcut.
And the fundamental principle here, the thing that guides everything we're about to discuss, from blood supply to nerve function, is embryology.
Exactly. For the entire GI tract, but especially here, everything from the caecum up to, say, the proximal two-thirds of the transverse colon originates from the midgut. The remaining third, all the way down to the proximal anal canal, that comes from the hindgut. And that boundary isn't just theoretical. It defines the major vascular and nerve systems we'll talk about.
So understanding that split is the key.
It's the key to mastering this whole segment.
Okay, let's unpack this. Let's start tracing the path, visualizing the colon as it sits in your abdomen. We begin in the lower right quadrant, right, where the small intestine empties into the caecum. We travel straight up the right side as the ascending colon, take a sharp turn left near the liver.
That's the right colic flexure.
And then we cross the abdomen as the transverse colon.
And that transverse segment is one of the most variable parts. It hangs in this loop, often dipping down.
Like a hammock?
Kind of. It has what we call an antero-inferior convexity. Then we hit that second corner, the left colic flexure, which is critical because it's usually positioned higher and tucked more posteriorly than the right side.
And it's right up against the spleen.
Nestling right against it. From there, we go down the left side as the descending colon, transition into the highly mobile and twisting sigmoid colon,
which loops through the pelvis.
And finally, we arrive at the rectum. It begins neatly anterior to the third sacral vertebra before it angles down into the anal canal. So that's our roadmap.
So why does the large intestine look so different from the smooth small intestine? There are some defining features, right?
4 of them. 4 defining external features that make it instantly recognizable, and you really have to internalize these.
Okay, first, the diameter. It's much larger. It's the large intestine, after all.
And it's generally widest near the caecum. Second, instead of a continuous outer muscle layer, the longitudinal muscle is condensed into 3 thick bands. These are the taeniae coli.
The taeniae coli.
Think of them like 3 shrinking elastic bands running down a long, soft tube. Their tension is what pulls the wall inward.
And that's what creates the puckering.
The puckering is the third feature, the haustra. Those little sacculations or pouches you see on the surface.
Right. And inside, they look like little folds.
Incomplete septations, yeah. And the fourth visual cue are the omental appendices, little fat-filled tags of peritoneum scattered over the surface.
But not everywhere.
Not everywhere. They're notably absent from the caecum, appendix, and rectum.
Okay, let's talk about movement, or the lack of it. Development dictates which parts are fixed and which are mobile.
Right. So if we connect this to the bigger picture, the ascending and descending portions are usually fixed. They've adhered to the retroperitoneum during development.
So they're plastered to the back wall.
Essentially, yeah. But the transverse colon and sigmoid colon remain mobile. They're suspended freely by their mesenteries.
And what's the clinical importance of this fixed anatomy?
It defines the surgical planes. When you're operating near those fixed segments, you use a critical connective tissue plane known as Tolt's fascia.
Gold is fascia.
This fascia separates the retroperitoneal colon from the structures on the posterior abdominal wall, like the kidney or the ureter. It is the surgical highway. You have to stay outside this fascia to avoid damaging those deeper structures.
Got it. Okay, focusing now on the midgut segments. The caecum is our starting point. A blind pouch about 6 centimeters long.
And it acts as a receiving and storage area for all that semi-liquid chyme arriving from the ileum. What's fascinating here is that because it's the widest segment, it's also the segment at the greatest risk of perforation if there's a severe blockage or too much distension.
So radiologists are always checking its size.
Always. Inside, you can actually see the landmark where the 3 taeniae coli converge on the caecal wall. It forms this kind of trefoil pattern.
And right next door is the ileocaecal junction. The small intestine doesn't just dump its contents, right?
No, not at all. The terminal ileum actually projects into the lumen, forming a protective structure. It's called the ileal papilla, and it has two distinct lips.
So it's not just a doorway, it's more like a gate.
It's a security gate. It provides a functional separation. It impedes the reflux of bacteria-rich contents back into the sterile small intestine, and it regulates forward transit.
And this area can get into trouble.
It can. If the caecum has a really narrow mesentery, that entire region is susceptible to twisting a dangerous condition called a caecal volvulus.
And here's where it gets really interesting. The appendix, often dismissed as vestigial.
Right.
This narrow tube, usually 6 to 10 centimeters long, joins the caecum posteromedially, and it has a unique feature.
Yes, unlike the rest of the colon, its outer longitudinal muscle layer is continuous. It's not segmented into taeniae.
It's amazing how variable its position is.
It's all over the place. It can be retrocecal, pelvic, retrocolic, and microscopically, the appendix is absolutely loaded with lymphoid follicles. It's basically a highly specialized immunological organ.
Even if those follicles do atrophy later in life.
Exactly.
And its clinical presentation is the classic example of dual innervation. Acute appendicitis starts with that poorly localized pain referred to the umbilical region.
Right, because the initial pathology is deep. It's carried by the midgut visceral afferents.
But then, once the inflammation breaches the surface and irritates the parietal peritoneum,
The pain shifts dramatically. It becomes sharp and localized in the right iliac fossa because now it's carried by the somatic nerves.
and that shift is everything for diagnosis.
It's critical. And circling back to its function, the source material notes this growing evidence that the appendix might be a vital reservoir for normal gut flora. It could help you recover faster after severe diarrhea.
So it's maybe not so vestigial after all.
Might not be.
Okay, let's cross the embryological divide now into the hindgut segments. The left colic flexure, which we said is higher and more posterior, is anchored by the phrenicocholic ligament.
That ligament is clinically important. Because of its proximity to the spleen, if there's extreme downward traction on the colon during an operation, there's a real risk of tearing the splenic capsule.
Ouch.
Yeah. Moving down, the descending colon is narrower and retroperitoneal.
And then we get to the sigmoid colon. It's famous for being so variable, right? Just looping around in the pelvis.
It is, and this area is particularly susceptible to diverticular disease, specifically where small arteries have to penetrate the circular muscle layer, creating these little weak points that can balloon out.
Now we arrive at the rectum, starting at S3. This is where the colon finally gives up its defining features.
It does. Remember the taeniae coli? They broadened out and merged just before the rectum. So the rectum has a complete longitudinal muscle layer.
Which means no haustra.
No haustra and no omental appendices.
It descends following the curve of the sacrum, but then it curves sharply backward.
That's the anorectal flexure. It's an essential angle for continence, and it's maintained by the sling-like pubo-analis muscle.
And internally?
Internally, the rectum has three prominent permanent folds. They're crescent-shaped. They're called the transverse rectal folds, or the valves of Houston.
And they're essential landmarks.
Absolutely essential for any scoping procedure or surgical planning.
This brings us to a critically important clinical structure, the mesorectum.
Right, so think of the mesorectum as this fatty package or bubble surrounding the rectum. It's packed with all the necessary vessels and lymph nodes that supply the area.
Sorry.
And this package is contained within a very distinct layer of connective tissue known as the mesorectal fascia or fascia propria.
So why do surgeons get so excited about a layer of fascia? What does this mean for someone facing rectal cancer?
It means that the entire package has to be removed intact. The surgical gold standard is called total mesorectal excision, or TME.
Gamma.
And the procedure requires the surgeon to dissect meticulously outside that fascial plane. That's how you get all the lymph nodes and minimize the risk of recurrence. It's a very delicate operation.
Why so delicate?
Because, laterally, the inferior hypogastric plexus, which controls urinary and sexual function, is sitting right there. It's closely related and you have to carefully preserve it. Maintaining that fascial integrity is truly life-changing for the patient.
Okay, so this is where that embryological split really defines the entire system. We have two major arterial supplies for the large intestine.
We do. First, the superior mesenteric artery, the SMA. It feeds the midgut derivatives.
So that's the caecum, ascending colon, and the first 2/3 of the transverse colon.
Right, via its ileocaecal, right colic, and middle colic branches.
And second.
Second, the inferior mesenteric artery, the IMA. It feeds the hindgut derivatives. The distal third of the transverse colon, the descending sigmoid, and the superior rectum.
Via its left colic, sigmoid, and superior rectal branches.
Exactly, but the body has this fantastic fail-safe built in, the marginal artery. It's a continuous arterial arc formed by the connections, the anastomose, of those main colic arteries running parallel to the colon wall.
So it's like a backup generator, a critical collateral lifeline.
It is. It can dilate massively if the SMA or IMA is compromised, preventing a sudden total loss of blood supply.
But it's not perfect.
No, the network isn't perfect. The source material notes that the junction near the left colic flexure is a watershed area. It's the farthest point from the main collateral feeders, which makes it the most susceptible part of the colon to ischemia.
And the venous drainage.
Mostly follows the arteries, flowing into the hepatic portal vein system. But the rectum is a unique venous nexus. It mixes circulation. The superior anorectal veins drain up into the portal system via the IMV.
But crucially,
The middle and inferior anorectal veins drain into the systemic circulation via the internal iliac and pudendal veins.
so this dual drainage creates a portal systemic communication site, which explains why things like hemorrhoids involve both systems.
Precisely. And finally, innervation is all about dual control. The parasympathetic system, vagus for the midgut, pelvic splanchnics for the hindgut, is primarily motor and secretomotor.
It speeds things up.
It does, and vitally, it causes the involuntary internal anal sphincter to relax.
And the sympathetic system does the opposite.
Generally, yes. It originates higher up in the thoracolumbar segments. It's mostly inhibitory to the gut muscle itself, but it causes the contraction of the internal anal sphincter.
So it promotes continence.
The system is perfectly balanced for holding things in until it's time to let them go.
And that brings us to the final stop, the anal canal.
Yes, the final stop. It's short, only 2 to 5 centimeters long, extending from the pelvic diaphragm down to the orifice. And it's directed posteriorly because of that sharp anorectal flexure we mentioned.
Continence is all about a high-pressure zone created by two key rings of muscle. First, the internal anal sphincter, the IAS.
That's the thickened, circular, smooth muscle layer. It's involuntary, it's tonically contracted, and it's responsible for about 80% of your resting anal tone.
And surrounding that is the external anal sphincter, the EAS.
The EAS, yeah. It's larger, it's striated, it's voluntary muscle controlled by the inferior anal nerve, which is a branch of the pudendal nerve. And these are type I fibers, so they're designed for prolonged, continuous contraction.
The absolute key anatomical landmark here, the point where everything changes, has to be the pectinate line.
It is. Think of the pectinate line as the GI tract's equivalent of a border crossing. Everything changes there.
Okay.
Everything above the line is derived from the hindgut. So it has columnar epithelium, visceral innervation, meaning poor pain sensitivity, and it drains into the portal system.
That's where internal hemorrhoids form, the ones that don't usually hurt much.
Exactly. But below the pectinate line, the tissue transitions abruptly to stratified squamous epithelium. It gets somatic innervation, which means it's acutely sensitive to touch, temperature, and pain.
And it drains into the systemic circulation.
Correct. This is where external hemorrhoids or anal fissures occur, and they are famously agonizingly painful.
So defecation is this beautifully coordinated effort.
It really is. When stool enters the rectum, it triggers the rectoanal inhibitory reflex, forcing that involuntary IAS to relax. Then, with voluntary effort, the EAS relaxes, the pubo-analis straightens out the flexure, and evacuation happens.
So continence is just about keeping the pressure in the canal higher than the pressure in the rectum.
That's the principle.
Yeah, so we've traced this entire complex final structure, all guided by the precise details of Gray's Anatomy.
Yeah, we have. If I had to boil it down, the 3 major takeaways that define this region are: 1, the embryological split dictates the arterial supply, SMA versus IMA, and that subsequent ischemic vulnerability at the watershed.
Right.
2, the crucial clinical relevance of the mesorectum fascia in surgery. It defines the plane for TME and protects that hypogastric plexus. And 3, the pectinate line. It completely divides the anal canal, defining pain sensitivity, venous drainage, and surgical significance.
Here's a final thought for you to mull over. If the appendix is indeed a safe house for beneficial gut flora, as current research suggests, what might the long-term subtle health implications be for the millions of people who have had an appendectomy? Does this tiny, often removed structure play a much larger protective ecological role than we give it credit for?
It certainly makes you rethink what we label as vestigial.
It does. Thank you for joining us on this deep dive into the anatomy of the large intestine. We hope this knowledge provides the foundational structure for your continued exploration.